So thank you, Laurence. So it's my pleasure to introduce the first speaker, Emilie Sbidian, which is a dermatologist in Créteil, in France, and professor of therapeutics. She will present the recent update of a Cochrane review called Systematic Pharmacological Treatment for Chronic Plaque Psoriasis, a network meta-analysis.
Thank you very much for the introduction. And now, since 2018, we've worked with Laurence and Sivem on the systematic review and network meta-analysis for systemic treatment for psoriasis. And I'm going to present the update 2025. So psoriasis is a frequent chronic inflammatory disorders that affects 2 to 3% of the world population with skin and rheumatologic involvement. For a subgroup of patients from 15 to 20%, we need systemic treatment, and these treatments are only suspensive. The number of available treatment for patients dramatically increase over time, with less than 3 systemic treatments in the 19s and more than 15 to date. We can classify the systemic treatment in 3 categories. The first one, the non-targeted treatments with fumaric acid ester, cyclosporine and methotrexate. The second one with synthetic targeted treatment with a group of phosphodiesterase 4 inhibitors and apremilast. The TYK2 inhibitors with deucravacitinib. And the third and most important category, the biologic targeted treatments, most important by the number of available treatments, 4 different classes: TNF inhibitors, anti-IL-12/23, anti-IL-17, and anti-IL-23. There is a color code, and in purple you have the drug that have been labeled in Europe, North America, but also in Russia for netakimab, and in China. So there are still drugs with trial ongoing, and all these drugs in phase 2 or 3 were incorporated in the new update. So all these drugs have shown their efficacy against placebo, and that leads to their approval. And now the question is how to choose the right systemic treatment for given patients. And to answer to these complex questions, you need at least a ranking in terms of efficacy and safety between all these drugs. So that's why we use a useful tool, network meta-analysis, that allows for a comparison of several interventions in a single analysis, including a comparison between 2 drugs that have never been compared directly in a randomized controlled trial. So this is really helpful for patients, clinicians, and guideline developers in case of missing comparison. This is our selection criteria for the review. All the RCTs phase 2, 3, and 4 dedicated to systemic treatment for moderate to severe psoriasis in adult could be included. Systemic treatments include non-targeted treatments as well as synthetic and biologic targeted treatments. The comparators were the placebo or one of these systemic treatments, and we chose 2 main outcomes: one for efficacy, PASI 19, and one for safety, the occurrence of serious adverse events. PASI 90 is 90% of improvement compared with a clinical score at baseline, and we can consider that this is an objective outcome as it's a marked improvement and clear or almost clear for patients. These two outcomes were recorded within the induction phase, meaning within a 6 months period after randomization. For each systematic review and each meta-analysis, including network meta-analysis, we need to assess the certainty in our results. We use for this review cinema approach, which is based on 6 different domains: heterogeneity, inconsistency, and indirectness. We will see later what it means. Risk of bias tools, and we use a risk of bias 2 of the Cochrane, imprecision, and reporting bias. So for each comparison, for each outcome, we will cut from very low to high certainty in the results of this comparison. So let's talk about the main results. I've just said that it's a living review, and we have started in 2018 with 100 RCTs, close to 40,000 participants. And to date, for the last update, more than 200 RCTs were included in the systematic review, and close to 60,000 participants. This is a dynamic review, and you can see that some treatments have been withdrawn due to lack of efficacy or due to severe side effects such as alifacept. And in the opposite, for new treatments are always added, and in the last review we had 6 new treatments, mainly majoritarily synthetic targeted treatment, phosphodiesterase 4 inhibitors such as roflumilast or rifamilast, and also TYK2 inhibitors, as well as IL-17 inhibitors, or the first oral IL-23 inhibitors. Another way to see that this review is dynamic is to have a look on the network plot, and you can. So there is a color code 2. The intervention of the same classes shares the same color. In red, as an example, the TNF inhibitors. In purple, the IL-17 inhibitors, and you can see that over time more and more direct comparison between 2 different drugs are available, and this is a really good thing for the results. So for our 2 outcomes, first for efficacy outcome and the PASI 19, you can see in the network plot that some intervention have a low number of participants, and especially the most recent one. And this is here the interval plot, and this is a way to rank drug in terms of efficacy, but it's not a way to compare the drug 2 by 2. So we don't know if the most effective drug here, Xiligekimab, is better to infliximab, which is the second treatment. So this interval plot can't answer to these questions. We have the same thing for serious adverse events, and so a less direct comparison in the network plot. And the main result is that we didn't show any difference between the occurrence of serious adverse events between the drugs and the placebo. So this is my favorite table in network meta-analysis because you have all the results of this Cochrane summarized in this table. On the upper side, you have the 2x2 comparison for the occurrence of serious adverse events, and in the lower triangle, the same thing for PASI 90. So you have here, in the last line, the result we've just seen with the interval plot, so the comparison of each treatment against placebo, but you have also all the comparison between all the drug of the review. And we have a color code, again, in green, the high certainty of evidence, and you can see that there are a few green rectangle, the moderate certainty of evidence in blue, it was the majority of the comparison, and a low certainty of evidence in yellow. And for the occurrence of serious adverse events, the majority was low certainty of evidence due to imprecision. So our results were consistent in each sensitivity analysis when we only kept RCTs with at least 50 participants, when we exclude RCTs at high risk of bias, when we keep only completers, and so on, which was reassuring for the internal validity of the review. So this is another slide for useful in clinical practice, because we did the same job only for approved drugs and those approved. And you can see that infliximab, ixankizumab, risankizumab, brodalumab was the most effective treatment for reaching the placebo, and in the league table there was no difference between all these drugs. When performing a network meta-analysis, some assumptions are needed, such as transitivity. This is an assumption under which indirect comparisons are valid, that implies no major differences regarding important factors that may affect the outcome. And our review respected this transitivity. And you can see on this plot that the severity of the disease was the same across trials, the weight of the patients too, as well as the proportion of male, and the mean age of participants. You need also to check the consistency, meaning the agreement between direct and indirect evidence. This is the statistical manifestation of the transitivity we've just seen, and we evaluated it both locally and globally. And this is an example. The direct comparison between risankizumab and placebo show a coefficient at 3.4, and the indirect one at 3.3, meaning no differences between indirect and direct comparisons. That's why we need a lot of loop and a lot of direct comparison. The more loop we have, the better it is, because we can check the consistency of the review. Lastly, we assess the heterogeneity of our results, meaning that it will underlying differences between the studies that directly compare the same pair of interventions. And so we evaluate this heterogeneity for each direct comparison using the I-square statistic, but also in the entire network with the estimated heterogeneity standard deviation parameters. We also have a look on the prediction intervals, and no heterogeneity was recorded. So So, to conclude, infliximab, xeligikimab, bimekizumab, ixekizumab, and risankizumab were the most effective treatments for achieving PASI 90 in patients with moderate to severe psoriasis, with high certainty of evidence for bimekizumab and a moderate for the other drugs. But this evidence was limited to induction therapy. But we have to be careful. Low numbers of studies were observed for some intervention, especially for the new drugs, and the populations was not the one we treat in daily practice. Younger patients with a high level of disease severity, with a PASI at 20. I'm not sure that there is a big difference between risankizumab and ustekinumab for patients with a PASI at 8, but we don't know and we can't answer with our review. And we need more information on the safety of this treatment. And Laurence mentioned it in the introduction. Robin Guelimi and Sbidian are conducted a new Cochrane review on the safety outcome for the same treatment for psoriasis, including both randomized and non-randomized studies. Thank you for your attention.